2. If everybody's ready, then we'll just crack on with the next item on the agenda, which is 3.4 self-directed support, and that's a report. And I think we have James Bain. James, are you going to present this for us?
Thank you, Chair. Thank you, members. So just want to kind of take you through the background of this report. It's quite a detailed report with 5 appendices. Stephen, thank you for putting the appendices separately into the chat. I think it helps. So just want, in terms of the summary, just to give a little bit of background. There have been reports to previous committees through the IPQR of developing work linked to option ones. And I know Ian Thompson has been developing a lot of work around the strategy. So there's been a lot of discussion around self-directed support. Just want to highlight this is one of the core enabling parts of that overall strategy that we're here to talk about today. So in terms of the outcome of the report, just want to really work with the committee just to give them some progress around the work we've been doing to establish a co-produced reference hourly rate for option ones in partnership with the SDS peer support group. Very much to give you a bit of background, this is one of the only ones in Scotland, I think. The SDS Highland peer support group are made up of recipients of family members of those that are involved in organising option ones. There's about 10 or 12 members. They're supported by a couple of officers from NHS Highland. So just to be clear, that SDS Highland peer support group involves actual users and family members of those that are receiving services, which is really important. So the ask from them at the start was to come up with a fair, transparent and mutually understood personal assistant hourly rate for personal assistance for our option one. That was the ask we were set. Very much focusing on the co-production, engaging, and more importantly, listening to service users at the outset. So in terms of that overview that we've talked around here, in terms of the situation, we were given an ask, I think, back in March 2022 to start to explore the true cost of care. A challenging question, I have to say, from them, but one that we were up for discussing with them, to work with them to make sure that they could see option ones as a positive alternative to other traditional delivery methods. So that was really key for the group. Around that overall SDS strategy and the update, costing care and identifying budgets was identified as a real key component of that, and it's been shared with committee. We think this should support the exercise of choice by ensuring that the recruitment and retention of valued personal assistance is a realistic, but more importantly, sustainable option. So in terms of, we were upfront at the start, the rate has not understood, it's not been worked up with users. So we were kind of working with a kind of blank canvas with our option one recipients, which we started with. I think NHS Highland was really clear that the rate that we started off in 2.15 is not defensible, it's not sustainable, and it requires updating and modernising. I'm hearing a lot about recruitment and retention stressors and competition around recruiting staff, and part of this is to address some of that challenges we've got. So just about 216, all integrated joint boards and local authorities have a statutory duty to offer and provide all 4 options, and the overall care budget needs to be realistic in terms of meeting assessed care need. We are aware of lots of cases across the spectrum of people that are receiving option ones that they're unable to access the care, which is not good. They're unable to access the assessed level of care, so therefore there are risks that we're managing on a day-to-day basis with that. So just to highlight there around the background, it was held at a low hourly rate for many years. It's not kept pace with inflationary and staff cost overheads. For example, the rate uplift this year was 3.3%. Most of us will know that the inflation is anywhere between 8 and 10%, and it's more acute on lower income households. So that's something that really needs to be taken into account in terms of the challenge we had setting that rate. Just to give you some background around the numbers of people we have that are receiving the actual option one in 2.22. We've got over 600 people, which is really good, who are receiving an option one as at May. Big increase during since 2022, an increase of I think 23%. I think to me that highlights the unavailability of other care options and a real market shift. In some areas, this is the default option. There is not the provider to provide care through a traditional option 2 or a traditional spot purchased care model through option 3. So option 1 is in some communities all they have. So again, in terms of the area we're seeing most growth is very much linked to option 1. We're seeing reductions in our delivered care at home. We're seeing reductions in our available beds for external care homes, as you've seen in previous reports, and you'll see in the IPQR. But the one area we are seeing growth, despite the low rate, is option one. So I just want to really highlight that in terms of the composition. So around the people, the 600 people that are receiving the option one support, I think 82% of them include an element of personal assistant input. So that's really important in terms of the reliance they have on the personal assistant component. The rest is made up of short breaks and innovative care packages. So again, in terms of the commitment from NHS Highland, we spend in excess of 11.4 million projection based on the younger adults and the older adult demography that's receiving option ones, and it is detailed there on the appendices in 2 and 3 if you've seen the full report. So just in terms of the co-production, and it's really important for myself, very empowering actually listening and talking to people, going right through this whole process. I think other authorities should do that a bit more when they're talking to people about rates and how these rates are put together. So we've had 8 individual meetings with the peer support group since March, and we have had lots of discussions around what a reference model would look like, and really good, open and challenging conversations right throughout the whole process with them. Just want to highlight here, it's not just about growing the number, it's about the independent support, especially in section 2.25. Ian has been previously with work around the self-directed support strategy, and there are 5 key work streams that he's been working on that require systematic change and systematic support. So one of these directly related areas is really important that sits aside alongside this is the level of independent support across all the options. So just to highlight in 2.25 for Scottish Government funding we have, which will be set up to procure independent sources of advice, information and support. Bex Barkin and others and the people we've worked in the co-production of this have been providing some of that support, but there are other organisations that people can access. So just generally in terms of that background, I think that's quite important for myself. So we acknowledged, as I say at the upfront, that there was a particular issues around the rate. The rate needed to be modernised and needed to reflect the actual requirements of employing a personal assistant. So when we started off this journey with our SDS Highland peer support group, it was imperative that any starting point for the calculation should be based on the Scottish Government minimum pay requirement. So section 232, it references there the requirement to pay at least £10.90. So any model has to start with that in mind. So for example, last year's rate was £15.1, this year's rate was £15.52. It was a 3.3% increase, and that's very much just linked to the 1050 to the 1090. So in terms of what kind of model would be worthwhile to look at, we had conversations with the group. We looked at our current care at home Highland pricing model. It's got a 3-tiered range of rates for urban, rural and remote. I'll explain a little bit more about the composition and the numbers that we have. But of course, it takes account of travel time, it takes account of cost of mileage, multiple visits. So it's adaptable, but it's not directly transferable to option one. We want to be really upfront here that we want a transparent and understood methodology, so they're clear about how we've come to this rate, how this rate has been put together, and essentially describes the overheads and the staff costs. So we worked with the team doing that. So in terms of the first 2 or 3 meetings we had, talked a lot around a particular model, talked around any other kind of areas that have got an all-encompassing rate. They don't. Lots of parts of Scotland are looking at developing work with personal assistants, but no one is quite looking at the hourly rates. They're very different across the piece that we work with. So the ask from the peer group in 2.33 was to consider and agree all relevant overhead percentage costs. That was really important for us to make sure we were on the same page. I posed a question to them. Do we want to have one hourly rate, or do we want to progress with something that takes account of the demographic challenges of Highland, i.e. urban, rural and remote? And I'll talk a little bit more about that. They also, an ask is because of the specialist nature of some of the people that are receiving this, do we require a bespoke specialist rate? That's phase 2, but this model will help to support that moving forward, because we are aware there are lots of complex and lots of specialist packages out there that we've got for option 1 that we need to support, and there's not a one-size-fits-all for this. One of the guiding principles for us was that any agreed model is not just for this year. It has to be aligned to future annual inflation uplifts, and it must be subject to funding from Scottish Government. That was really important, that we wouldn't go through this exercise each year. So we wanted something that was aligned to an annual uplift and aligned to Scottish Government funding. So in terms of the start, I think it was September 2022, we provided lots of information to the peer support group on a kind of geographical split across Highland, so exactly where people are. That's in Appendix 3, and it describes some fictional case examples that really brought it to life, postcodes for locations, and also the split by urban, rural, remote. So I can talk a little bit about that particular detail, but it's on Appendix 3 that shows the map of existing service users, the postcode definitions to location, and it also shows some of the fictional examples we went through when we were having the conversation about whether or not this was one hourly rate or moving to urban, rural, and remote. So as I say, it's after many good and equal conversations, NHS Highland, community contacts, and the peer group agreed a co-produced solution. So that co-produced solution was that urban, rural, and remote rate. It's based on adapted methodology using that UK Home Care Association, but they liked it. It was transparent, and they could see the merits of having something different for our urban communities, our rural communities, and our remote communities. I think at the moment, I'll just throw some numbers in. We've got 40% of our option 1 recipients are 65 plus, 60% are less than 65. And it's quite important to show the different demographics we have with our care at home, for example. So taking into account the new rate, the model is there, I think, in Appendix 4. So the current rate's £15.52 per hour. We came across with a model suggesting an urban rate of £16.67, a rural rate of £17.37, and a remote rate of £18.7. Now, I know that people will see the significant investment that's required for this, but this is very much about levelling up the rates required for these individuals to make a much more attractive, sustainable, and fair option for option 1 recipients. In terms of setting this in context, I've got in the paper around 237 is that I don't want people just looking at the option 1 rates and looking at the increase. We need to look at what we pay providers and what it costs to provide services ourselves. So just I've got a couple there that I've referenced. You've got the care at home urban rate at £22.45 an hour. You've got the care at home remote rate at £27.69. And you've got our in-house current care at home unit cost in excess of £50 per hour. So as you can see, it is very much option 1, the most cost-effective and efficient model that we have. And also it ticks all the boxes around promoting choice, flexibility, and control, although I know it's not for everyone. So in terms of the proposed level of assurance, we started off with discussions around financial funding as we've gone through the route to the meeting. We settled on moderate, so I'm pretty much looking, cannot control the sort of individual circumstances around each option, but to me the assurance level specific to the proposed reference rate, the significant consultation input and co-production with actual users of services, and it's viewed as moderate. So it's just for the committee to agree whether or not they think that's appropriate or not. Just to be clear, the fee rate model supported by detailed information-led collaborative design solution, which demonstrates the transparency of approach. We've had that checked all the way through the process by a very challenging group of individuals I've got to know very well that actually have worked really well with us to produce this co-produced model, which has been really good for them and for NHS Highland. Just to be clear here, it is a financial pressure. All financial pressures are monitored through the Joint Officers Group, which is representative of the senior officers of both NHS Highland and Highland Council. So just around the sort of impact analysis that we did, we know there's significant recruitment and retention challenges everywhere, but what we do think that this proposed increase in the option 1 rate will help acknowledge the geographical challenges of NHS Highland. It will help us to sustain these much valued local services, again supporting full flexibility, choice and control. In terms of the financial commitment, it's a very scary number, I appreciate. In terms of the full year additional cost commitment would be £1 million based on current information. I just want to be clear, though, around some of the processes and some of the safeguards we have around the standard operating procedures and the management of option 1s. In recent years, we've had significant accumulations have been recovered, and I would say before, during, and after the pandemic. It's partly due to the lower rate. People are not able to access the services that are assessed for. That's really important. I do think that despite the increase in the rate, some option one service users will still continue to experience difficulties, but this will help part mitigate that. But what we're effectively saying is any in-year accumulations will be offset against the financial pressure that we've discussed with our finance colleagues. So we do acknowledge that, I don't like using the word spend to save, because it's not appropriate for the option one, but this is very much a significant cost of investment. It is our most cost effective and efficient delivery model. And I think it's the one I can safely say that has grown, in particular in the last couple of years, unlike care at home, unlike support work, and unlike some of our other areas. So it's very much the growth model we have. So if, for example, last year we saw an increase of 23% in option one, if they had received a spot purchased option three service, that would cost an extra £10 per hour. It would cost a lot more in-house. So just want to set that in context around, it's not just about financial pressure for option one, it's also about, dare I say, the cost avoidance around option three and in-house costs, which is really important to take into the concept when we're talking about option ones. So in terms of NHS Highland, will continue as part of our core practice to promote all SDS approaches, and option one is a sustainable delivery model. That will happen. That's something that I know that Ian and professional colleagues are passionate about and are dealing right throughout our self-directed support strategy. Again, it's a investment and underpinning core element of the overall programme, and more importantly, there is that further investment to put independent support in place. So if we're growing option ones, there is the support for these people to sustain these complex packages as they require support, both in the setup phase and also the ongoing phase, which is really important. So in terms of the risks, just want to highlight the key risk is the rate differential in terms of what I brought out, and the sustainability of the existing delivery options. In terms of communication, there's been extensive communication involvement and consultation with the SDS Highland Peer Support Group, Community Contacts, NHS Highland. We've had a few show and tells with Self-Directed Support Scotland, the Health and Wellbeing Minister, etc. So this has been in quite a few places before it's come to Health and Social Care Committee. So just around that route to the meeting, just to be clear, we've had 8 meetings of the peer support group. We've had detailed discussion at the Adult Social Care Leadership Team. That meeting with the then Minister on the 18th of August, which was not just about this, was about lots of other areas we were developing in Highland. We worked with the Self-Directed Support Scotland. As I said, there's been mention of it in the RPQR, but not the level of detail that's in this report today. And it had been obviously discussed at the Joint Officers Group on the 14th of April 2023, clearly before it comes here. So before I kind of draw committee's attention to all appendices, just want to kind of roll back to each individual appendix. So appendix 1 is that Health and Wellbeing Minister showcase. That was showcasing some of the Highland developments, including the strategy in this work. Appendix 2 is very much showing that split by urban, rural and remote, which is really important. It came to the conclusion that we thought an urban, rural and remote solution was better than one hourly rate, which I'm really happy that we were supported by the peer group to do that. Appendix 3 has got your case studies, which, as I said earlier, brings out fictional examples, the postcode, and brings the actual model to reality and fruition for people that don't kind of understand accounting talk, and they really appreciated the Appendix 3. It brought to them how it would impact them for specific references. Appendix 4 is the model for transparency and awareness of how the rate's calculated. We've shared that right throughout all our process. That's there. That will be shared with our SDS Highland Peer Support Group and others. And the last thing in terms of Appendix 5 was just that internal overview that we used for a joint officer group back in March. So I just want to kind of take back up to the recommendation. It's to consider the information appendices and extensive engagement with SDS and other stakeholders in preparing this new co-produced model. And what I'm here for today is to look at committees to consider and recommend implementation of the new proposed reference rates from Monday the 3rd of July, noting the additional cost commitment for this year would be 750,000, which is based on the current service user profile. So And just generally a whistle-stop tour through 14 months worth of work. So if there, I just want to kind of pause there for any particular questions, any observations around the work, and any kind of clarification around the appendices. So thank you for listening.
No, thanks for that, James. I would say it's a wee bit more than a whistle-stop tour. It was very, very thorough in your explanation of the paper. What I will say is there is significant cost attached to this for this year, what's left of this year, and then ongoing costs of in excess of £1 million. So that's against the backdrop of the current cost pressures we've got. So I'll be quite interested in what the the committee have got to say with reference to this paper, and I'll invite comments. If there's no immediate comment, I just wonder if you could let us know what the joint officer group had to say about some of the costs and the pressures that are already been experienced, James.
Yeah, it's really difficult for me to comment on. I know there's no finance representation here today, and I think members mentioned that earlier in the meeting. I think Joint Officer Group have taken account of the financial challenges. I think they are seeing, for example, the option one being the most cost-effective option for so many people. I think I've highlighted that if we weren't delivering our services through our option one, it more likely be through our in-house services and our commissioned external services, which are more expensive. I think I just want to set out in context, though, is that we've seen a reduction in the last 2 years of 2,500 hours of external care at home at £25 per hour. That's a big reduction. We've got 40 to 60 less beds that we're paying for on the external sector, not by choice, around the care home closure, around some of the market sustainability. And I'd like to think if finance were here, they would see it very much in the whole, and they would see the totality of the adult social care budget rather than just looking at the pressure that's just for option one, because it is a lot more multifaceted than just option one, Jerry. Sorry, if that helps, Chair.
Yeah, thanks for that. I've got a couple of hands up, so I'd like to take in some comments. Cara, can we start with yourself, then Anne and Kay?
Thank you. Hi, James, and thank you so much for the report and the explanation. And it's clear that there's a lot of work that's been undertaken to get to this point. I mean, my question, and I think you touched on it briefly in your summary, was around about specifically bespoke rates. So some of the things that we see that coming up through funding panels are where there's 24-hour support packages under a direct payment, where they're finding challenges in terms of recruiting and retaining staff and thinking about the rates that they're paying. And I'm just looking and thinking that these are people who would probably come under the urban rate. And I was just thinking about what you'd mentioned and what the kind of future plans would be to review in terms of a more bespoke rate, where we're seeing some of those challenges in terms of 24-hour support packages under an option one.
No, thanks, Cara. The development of the bespoke rate is very much something that came up in the discussions with the SDS Highland Peer Support Group, and they recognise that complexity that we've got across the 610 people that are receiving a service. So I think we see this very much as phase two. What the model does give is it does give a starting point for us looking at that rate. As I say, it's predicated on the 1090 at the moment, the base rate we've used. But the bespoke rate, dependent on the complexity, I think I'd like to see a kind of set framework around that to make sure exceptionality was clear about when we're actually using that. So I think that's very much phase two of the development. But I think we're seeing a lot more complex packages that are a lot more difficult to sustain. That's not just down to the rate, it's down to the availability of staff. What came out really strongly in our first meeting I had with the SDS Highland Peer Support Group was a well-known fast food brand that paid X amount per hour, and we were paying X for a personal assistant. That was very empowering for me to hear that. But also it's about what is within the gift of NHS Highland and what we can actually work. And this has probably pushed the financial parameters as far as it possibly can around that. But I think what's important for me is that transparency, and that people now understand how we've got to the rates that we're proposing in committee, which previously wasn't the case.
Thanks for that. And Anne?
Okay, so I think Philip's set the context here. So first of all, James, thank you very much, and thank you to everybody that's been involved in doing this piece of work. I've been asking for a long time about the issue about our rates for option ones. So I'm delighted to see the culmination of this work. And I'm also delighted to see how it's been undertaken in terms of the collaboration and co-production that's been, that's been part of, that's led us to this point. So, I would love to be able to support this. However, given the context that Philip's outlined, I think, the committee has to explore that issue in some detail. So, and probably I've got more questions than we've time to go over today, but I just want to really emphasise, that I'm fully supportive of the ambition and the work that's gone into this. So, and hopefully some of this you might be able to answer very quickly, and there's a lot of information in there, so I'm very sorry if I've missed any of this. But I suppose the first thing I wanted to just ask you, yes, there's increases here in the rates, but they're still quite a long way off what we pay our independent sector providers, never mind our own provision. So I wonder if it may not be possible if you could quickly tell us whether that is actually based on some sort of rational evidenced formula, as opposed to just perhaps a recognition that this is as far as the financial envelope can be pushed at the moment. So could you answer that first of all, if possible, and then I'll move on from that.
I'll try. Yeah, I think in terms of the starting point for the model, we have got an adapted UK Home Care Association rate we use for care at home. So that's understood by commissioners. So it's that same model we've used. What we've effectively had to do is strip out the multiple travel time, the travel visits, and we've had to settle on the overheads, because clearly the overheads for a individual will be slightly different than the overheads of a large or a small scale operator. So that was one of the challenges we had, and I remember saying this to the peer group around defining the true. I don't know when anyone's defined the true cost of care. So to at least start that conversation and journey to bring us to that, I would say it's, if Ian was here, he would say it's not the panacea. It's the rates could be pushed more, but in terms of the overheads, I think the group all realised and thought that these rates bring them much closer to be able to compete in that market with other hospitality, other care providers and other areas. So yeah, very detailed, but I think the bespoke rate for me is one that we'd need to look at, but very much predicated on the 1090 starting point, including the staff costs, including the national insurance, superann, sickness, pension, etc. So all the boring staff costs have been taken up, and the overheads have been agreed with a premium for the travel, the mileage, and the other components linked in to the urban, rural, and remote rate. And one of the things that perhaps I should have said at the start, apologies for not saying, is that we've got really robust standing operating procedures here. If the money, the assessed care needs, the assessed packages are not delivered on, we end up recovering that. We act under instruction and business support. Very tight processes that we've got around this. I mean, the system itself is used by way of a payment card. So people find it really, really useful to use it that way. So in terms of that particular question, Alan, I would say I'd have liked to have gone further. I think most of the peer support group would. I was having to be quite realistic around some of the overhead costs, but I think we got the important ones in. I think we got the training, the supervisory, the retention of staff. That's all really important to put into the overheads, with some other overheads that were included in that one. The Appendix 4 does have that reference and how the model's been put together. I could share that with you separately.
Okay, I think that's fine, James. Thank you for that. So and another question I had, in terms of what the, so you've set out the potential overall cost. You've also suggested that that might be offset by, I think I'm right in saying, but I might have got this wrong, by taking into account monies that we might recover where people are unable to spend their allowance. So I suppose one of my questions is, in previous years, has that money that we've taken back been put against our non-recurrent savings, and therefore actually if we go down the road you're suggesting, that money will not be available to set to the bottom line this year?
Thank you for that question. You're absolutely right. And in terms of the cost improvement programme, just to be clear, we have got a much smaller amount against our cost improvement savings target this year. So we have built in some contingency and capacity to allow for the growth and the additional costs we have on. So you're absolutely right. The cost improvement programme, our adult social care savings plan, I think from memory, we've got £350,000 worth of accumulations in our cost reduction plan or our cost improvement plan. The rest of it will be mitigated against the park growth around accumulations. I don't want to use last year's number, because last year's number, it was contaminated by the pandemic and how really difficult it was for people to access care. But it was 1.7 million. And it's a huge amount of figure, and maybe some accountants and some people might like that recovery coming back in. I look at the more downside to that is that we're not actually seeing people who are assessed to receive services able to access that services in our communities we need. So yeah, I wouldn't like to put a number on the reclaims this year. It will certainly be lower than the 1.8 million. I'd like to think it would probably be something in between $750,000 and $1 million in terms of accumulations given previous trends.
Okay, so then to come to the overall, I suppose, picture, and for me, actually, this isn't a question for Elaine, and who's not here today. It's not a question for finance. It's a question for the senior leadership team. So I suppose then, and for the JOG. So I suppose I'm asking whether the senior leadership team and the JOG were content that effectively we're doing something that will put a cost pressure into the system given our finances. Absolutely, I can see that it may be cost avoidance, and I can see that it's the right thing to do. But I suppose that I'd like to hear what the overall conversation and decision was on that point from our SLT and from the JOG. Thanks very much. And in case I forget, the other thing that I'm really pleased to see is about the spend on the infrastructure to support the growth in option 1. So thank you for that. Okay, and that's me.
Thanks, Anne. That's helpful. And I think just to reiterate what you're saying there, I think there's a principle which I can't imagine anybody would disagree with, but the difficulty for me is recommending anything which we don't know where we're going to get the money from, and in the absence of some of the financial information which may have been available from Elaine, but Anne makes a point that it's about what the view of the senior leadership team and the JOG are. I think there is a gap in us having the knowledge for making a recommendation there. But I'll take the other members of the committee who want to add comment, and we've got Kay, Vanellen, and Jerry.
Hi, it's just to while it's good that everybody could get a service, I don't know how practical that is in terms of people to give the service and the cost for everybody who wants and needs a service to get a service. Within the costings, there isn't anything there for day services, which, in a comparison to that model, which I know it's not for everybody, but it it gives, having worked in day services when I was DCO, I could give a service to 6 or 8 people at once, you know. So therefore, in the cost effectiveness of a model, then you know, that's 1 worker to 6 or 8 people. If each of those people have self-directed support, then the cost is huge compared to like one person. So I know there's still day centres for older adults as well, and I just, you know, it's an ideal model that everybody could have their support worker to go to do what they want to do, and I think it needs to be in the mix. But if it's the only model, then it's financially not sustainable, and there's not the people in, especially in rural areas. We've just been talking about care at home and trying to get a service for care at home. There's not the model, and not the amount of people there to give, you know, the service that people want. That's my 2 main concerns.
It's okay if I answer them, Chair.
Yes.
Yes, thanks.
Okay, no problem. I just want to go back to the previous point around the joint officer group. There was costings associated with the joint officer group, but I think the point about it being around EGG and SLT is an interesting one. I don't think it's been discussed at that particular level, but the joint officer group were both cognizant of the additional costs at that time. I think that's just something I wanted just to go back. In terms of, I think, Kay's point, option 1 is not for everyone. This is not an option that we're talking about rolling out to every individual. 600 people are receiving an option 1. We probably provide a service to 4,000 or 5,000 people. So it is just setting it in context of the overall delivery. We've got 1,000 people receive care at home, X amount receive support work, X are in care home. So just to be clear there, that around the costing up of a personal budget, if there was an element for daycare and this person the person receiving an option 1 wanted to access an external and internal daycare service, they're perfectly able to do so. It's their choice. This is the choice and control that people have around the option 1, is that they choose how they spend that particular personal budget. So yeah, it isn't a one fit all, but it is something that is very important. And for lots of people, it's a very flexible, and I can see it being quite an attractive model, building up relationships with personal assistants. And the 600 people are already receiving a service, albeit it might not be at the full assessed level. Just wanted to make that point, if that helps, Kate.
Grant, thanks, James. I think the question of choice is key there. Dunellen, did you want to?
So actually, James's part answered what I was going to say. I was just wanting to come in, and we've had a lot of discussion around the finance and scrutiny of that, and appropriately so. I think just in terms of the, you know, it's just a reminder around the legislation. You know, it is the SDS Act, and we are legally required to discuss the 4 options. So, you know, in terms of Kay's point about a traditional service, if somebody wishes a traditional service, then that's still available. Not without its challenges, I have to say, when we're extending the range of choices. You know, we have got hybrid models, but because of the growing demand, we've not been able to close traditional services the way that maybe at the outset of the legislation was perhaps anticipated. And it is one size doesn't fit all. It is very much about the promotion of choice, flexibility and control. And for me, there is a really important principle or principles of equity and fairness, so that we know we've got people in rural and remote parts of Highland who absolutely rely on option 1 and who are very keen to go down that route, but our financial models just now don't support it. So it's just to get that in the wider context of, you know, being listening to what people are saying, and being, as you know, what the legislation does give us is the opportunity to be as creative and flexible as we can. And having said all that, I do accept the focus on the budget, but I would absolutely support, you know, James's analysis of it.
Grand. Thanks for that, then, Ellen. So if we can have Jerry and then Pam after Jerry, that would be appreciated.
I think, strangely for me, Philip, I'm actually going to be amazingly quick. I just thought it was important. I said, I think yourself and Anne have summed up exactly where I am on this paper. I am tremendously supportive of the principle, and I actually tremendously enjoyed reading the paper. And thank you to James for it, because I think it was set out so well, and it's actually the setting out that actually brings these questions to the fore. One of the aspects I particularly liked about the paper, although we're talking about potential cost avoidance, I think it would have been tremendously easy for James to do some convoluted calculation. It would have seen a conversion from care at home or in-house provision to actually demonstrate that this was cost neutral. Well, actually, we're probably not looking for it to be cost neutral, and it will be actually tremendously difficult to demonstrate that it will be, although we expect it to be. And even the issue about utilising the accumulations, actually, the ideal situation is exactly as James said, that people do actually take up the care. We don't actually have the accumulation, because that's where we would want to be. But I think we have to be very, very mindful, and apologies to committee, I didn't check the terms of reference. I'm not sure where this committee sits in terms of being able to add to our financial burden. We are, after all, a governance committee, and I think we have to be, whether we've actually got the authority to actually say, I think we could probably express a supporting principle, but whether we've actually got the authority to say definitively that we can do this. But I just wanted to go over that. I really support the principles underlying the paper, but I know that's not what everybody wants to hear, but we do have this albatross around our neck of money. Thank you, Philip.
Thanks, Jerry. No, that's helpful. Pam, then Anne.
Thanks. Yes, absolutely recognise the financial risks. You know, it was important to get this to the Health and Social Care Committee today. We really wanted it up front and centre, you know, in terms of that choice in co-production and that transformational change. That's really what we need to be doing at pace going forward. And when it came to the joint officer group, you know, we recognise the financial risks. We did debate these. You know, going back to some of the discussions we've had in the board around transformational change, about taking risks, about being less risk averse, about working with our communities and co-production, about changing services for people. Do we really want people to be going to traditional day services? Do we want to, you know, support them to actually access monies with their budgets to do something much more equitable and much more engaging, you know, as part of our community citizens? So there's a lot that will change as we implement this programme, and I think we have to look at the quality and the outcomes for people in doing so. It hasn't been to SLT for timing, because normally on a Wednesday at 1 o'clock we have our senior leadership team that we would have had this week, but we are here, so we're going to have to take it next week and take it through that governance process as well. But we just didn't want to delay it coming to the committee, because we felt it was so positive and so crucial, and it's part of the whole response to transforming how we work with people, how we engage them in being partners in their care, etc. So thanks, James, for presenting the paper. It's much complexity, you know, and for people to actually understand what we're trying to achieve is really difficult. And, you know, we absolutely understand the financial risks, but we really want to get away from describing services in terms of affordability and doing a bit of that risk taking and stepping forward boldly when we've co-produced it. You know, and I think that's really, really an important frame to remember. Thank you.
Thanks, Pam.
So I think it was really, I think Jerry's point's very well made. So I think we need to consider, and I can't remember exactly what it is at the moment, what we're being asked to do.
There are two things. It's to consider the report and accept moderate assurance from it, and then to recommend the implementation of the proposed reference hours. My view was that I think I would like to see us perhaps accept the principle of what is in the paper, but I certainly feel uncomfortable about our ability to recommend something that we have got no way of demonstrating where the cost is going to be picked up. And Jerry made a point that it's maybe ultra vires for us. It's beyond our authority to approve something in a governance committee, which has got a greater cost burden. Sorry, Anne, I cut across you.
No, that's fine. Well, I would be happy with that sort of approach at the moment, particularly as Pam's clarified that it hasn't been to the SLT. So I certainly wouldn't feel able to agree the recommendation as it's described when it hasn't been to the SLT. So I'd also like, so I think the other thing is to say that I think it's really good that we're having this discussion, and I think it's because, as Pam says, this is the kind of redesign type conundrum that we really need to be grasping quite clearly, and will need to grasp more and more over the coming, I'm sure probably many years. And we've probably learned a lot from bringing this to the committee in terms of, the kind of questions that we need to be able to answer when we are effectively investing to save, because I have ringing in my ears our Director of Finance's comment, will you please stop using the word investment, because we have no, okay. But I think for this committee and for this process of integration, it's particularly important that we see, I think, how the SLT and the JOG has considered the issue about, okay, so what is that? We think this is the right thing to do, accepting some risk here, but what do we think, the consequence of that might be? Or, is it that we'll have to find savings elsewhere? Or are we intending to ask the council to invest in the quantum in relation to this or not? So it's great that we're having this discussion, and please don't take away that, because we're saying we can't agree the recommendation, that's a criticism in any way. And, basically we're going to have to do much more of this as we advance our strategic plan. So.
Thanks, yeah. Thanks, Anne. Jerry, can I bring you in?
I think, Philip, it's really just to say I agree with Anne. I think I would be quite happy if we could amend not amend the minute, because we haven't written the minute yet, but if we could agree as a committee that we are fully supportive of the principles, but actually discussing its senior leadership team and taking into account the financial position of the entire partnership. Because I'm conscious as well that although it's a development session on the 19th of July, we could, and I'm not saying we want a paperback, but we could actually see it in that whole round there. And actually, but the important thing is that I think what I'm hearing is that we as a committee are fully supportive of the principle that has been set out in this paper, and we recognise, and I think Pam articulated it very well, if we're actually to make the transformational changes that we want, we're going to have to do some of this, hoping, expecting that it will make the impact that we want it to do, but in supporting the principles, because I think it would be, I will say, I think it would be very poor of us to reject it, and I don't think we're suggesting that just based purely on the money situation, because I think that would send out a really, really poor message to colleagues who've put such a lot of effort into this, and actually I have to say produce such a good product at the end of it. Thanks.
Thanks, Jerry. Neil and then Pam, thanks.
Hi, yeah, just really commentary from the periphery, as it were. James, that was just a really great presentation and very professional, very clear, and it's great that how you've involved all your clients and users. And I can only give you my support for the increases and the whole plan, as the others around the committee have. It's a shame that I don't have any input into the JOG or the SLT or whatever, because I think you should definitely, at the risk of upsetting the financial people, definitely invest in this. The problem with so many of these things is that your outcomes are going to be qualitative. They're not necessarily quantitative. And, you know, better health and well-being and a better life is really difficult to measure in terms of money.
Yeah.
And my colleagues will call bean counting. So I suppose one way of looking at it, or of I don't know, giving it a little bit of power to get through those hurdles, or over those hurdles, is that if we look back, and we're going to see on the IPQR that, yeah, there is a gradual diminution in use of care at home, either external providers or in-house, and that's not for want of us wanting to keep people at home and to use care at home. It's just the way it is, and there are external factors. And if, as a board, we're using monies which are, if you like, unfortunately saved from those areas to promote, push, develop a service which is clearly growing, you've given us the numbers, it's growing, then that's what we should do. That's just my thought.
Thanks very much, Neil. That's makes a lot of sense. And finally, Pam.
Well, the final point, I'm really conscious of time. I'm really heartened to hear the passion in the room about this, and the really people and carer centred focused discussion that we're having, you know, despite talking about the money. This is about transformational change and whole system redesign. So in terms of agenda planning for the next committee, we've been working on a number of transformational programmes and efficiency programmes, etc., that are going to come back to the next committee, and you will see them in the whole. So I guess taking it to the committee, there's a big part of the jigsaw missing about how we can proceed. So we'll intend to frame that you know, at the next meeting when we bring our transformation and efficiency plans that we've been working on. And sorry, border terriers going chaotic beside me. I really do apologise. Yeah, but it's been a really heartening discussion. So thanks everybody for your responses, because what we want to be is, you know, passionate about care and passionate about the people that we're delivering services for. And if we can develop our performance against the national health and wellbeing outcomes, if we can have feedback from carers and people who use services, that's going to be really powerful. And over time, services will transform and shape and redesign, and we'll get there. So thank you for that.
Thanks, Pam. I think that leaves us then in the position to reframe what we want to say in terms of something for the minute. And if I can just suggest that we may want to consider fully supporting the principles set out in the paper, but unable to recommend the additional cost without the reference of the financial information from the SLT or the JOG. The folk feel content that they're able to approve a change in that wording. Okay, that's thumbs up, and if we can record those formal words, Stephen, that'll be fine. Well, thanks very much for that. That was a huge amount of discussion, and I think, as I say, everybody is very supportive of it, and it's as I can't remember who said it there, but perhaps Jerry, the right thing to do, and we just need to go about it the right way as well. Okay, I'm really conscious of the time, so I'll push on, and if we can have the dashboard report next. Thanks very much.
Hello. There isn't actually much to add to the discussion, I don't think, from the dashboard today, because you've touched on so many areas of this already today. In a nutshell, it reflects your discussion perfectly. It's showing an increase in care at home unmet need, and also an increase in delayed discharges of 15 since the last report that was here. The care home occupied beds, however, remains static. On the good news is the psychological therapies waiting times, which is continuing to show a reduced wait, both for the longer waiters and also now into the under 18 weeks as well. There is also an additional slide in the pack, which was a request from the last group, the last committee meeting, and it's the second slide in your pack. And the request was to see the unmet need in terms of time. We break the times up, how many weeks of people have a certain number of people been waiting. So we've got here people who have been waiting up to 1 month is 67, between 1 and 3, 92, 3 to 6 months, 72, 6 to 12 months, 61, and over a year, 53 people. And the second graph on that page shows you the level of need that these people have had assessed, with the bulk of that being a substantial need. I think that's all I'd like to draw your attention to really today.
Thanks so much for that, Rhiannon. And if I can just open it up to members for any questions or observations. Joanne.
Thank you, Chair. I had a number of observations, but maybe in relation to the kind of time element for today, maybe it would be better to pick them up with Rhiannon out with. Some of them were around that it would be quite useful for some of the data to have comparisons from other months and trends and ongoing wait lists details. I've got 4 or 5, maybe 6 points, so rather than go through them all right now, if that would be useful, I could maybe pick some of it up with Rhiannon offline.
That's fine by me. That's fine with everybody else.
Excellent. Yeah, if you wouldn't mind even emailing those, Joanne, and pick them up with Rhiannon, that would be ideal. Anne.
So just, Rhiannon, thanks very much for putting in the new data about waiting times. That was a previous request, and it's good to see that here. So just picking up on that, I wondered if anybody could tell me what the approach is for this particular service in terms of a balance between, I suppose, getting waiting lists down versus new assessments of need. I wasn't quite sure how we approach that in relation to this particular service. So, you know, is there any consideration given in terms of the decision as to, you know, who gets the next available slot, about how long people are waiting, or is it all done in terms of who has the most critical and substantial needs at a particular point in time, you know, when a capacity becomes available? I guess that's what I'm asking.
I don't know who wants to come in there.
I hope that sounds, maybe it doesn't make sense. Sorry about that, but.
No,
yeah, managing waiting lists are multifaceted. You know, people will be taken in all different circumstances in terms of how diseases have progressed, the impact on people's lives, how that shapes and changes, how they're being reviewed, etc. So it's not really an easy question to answer, but one that we consider more at the board when we have the IPQR. And we can maybe reflect that definitely in partnership with acute colleagues, going back to the papers I presented earlier around you know, that whole balance system. You know, so people wait all sorts of time in all sorts of places for all sorts of different things. You know, care at home just being one of them, but we can definitely reflect on that. What we want to avoid is people waiting at all because of deconditioning. So yeah, okay. I'm not sure if that answers your question. Daniela, do you want to come in?
So in relation to assessments and people waiting for care, whether that be care at home or support work or a care home, we now have the daily decision-making teams, which are multidisciplinary in each of the areas, and they have got a focus to facilitate flow and pull from hospital, but also to avoid inappropriate admissions. So they've got early insight into people in the community who either are in need of some care or are in need of an increase in care. And so the MDT decisions are around, there is really good discussion on a daily basis, on Monday to Friday, around the priority folks. But there's also discussion around, so you've got care at home around that table, you've got district nursing, and OT, physio, you've got a range of professionals, social work, and there's also then the problem solving, the discussion around, so, you know, what can we do collectively? There might not be immediately the care available, but that's when things like we've already referenced the reserves, we've got the care response team, so we're looking at what we can mobilise to actually keep a person at home or to facilitate. And there, as you might imagine, there are very often very competing priorities. So, you know, the role of the district in terms of determining who's the greatest, you know, in terms of that pool. You might have somebody in hospital where guardianship's been granted to get the move, but you've got, you know, a couple in the community who are really teetering on the brink. And it's around, so these daily discussions around around the competing priorities, and it is a collective decision around how we manage that.
Okay,
I hope that helps.
Yep. No, I think that's the kind of assurance that I was looking for in terms of, you know, how we approach that very, very difficult balancing act. So thanks for that, Danellen. So I only had, well, as there's lots of questions you could always ask, but there's no time for that. But the one other thing that I noticed from this time round, I just wanted to ask, maybe we don't know the answer, and that was a reference to some of the data being produced manually. And I just wondered how much of the data that is presented here to us is produced manually as opposed to, you know, at the touch of a button, so to speak, or at the request for an interrogation of a database. Are you able to tell us that, Rhiannon, or? You know,
I can give you an overview without going into the detail.
Yeah.
So anything that's not reported directly to government may well be produced by hand. So we'll be looking at the community mental health data and also the last page, the non-reportable specialties. Anything that's a government requirement, and certainly all the adult social care data is not hand collected.
Okay, right. Thanks. Thank you.
Okay, thanks very much for that. And if there are no further questions, we'll look for the committee to accept moderate assurance from the report. So do we accept? Yes. Okay, we've got the thumbs up for that. And then we'll move on to Chief Officer's report. Pam.
Thanks. Very, very conscious of time, so I'll go on the premise that people have read the paper. I've gone and done a quick update just around our major service redesign programmes. So we have been over in Skye. There was a meeting of the Sir Lewis Ritchie Implementation Steering Group. So really good collaboration between commissions, amongst clinicians and partners around you know, moving forward with our urgent care model in the north part of the island. There was an opportunity to look at the district profile as part of the joint strategy document, and we had a really good discussion around care at home, and people were really engaged, which was really good because the focus of the meeting was on urgent care, but we definitely got into you know, people engaging a bit more proactively around the forthcoming engagement that they'll have around the strategy. So that was really a positive takeaway for me. In terms of the Lochaber redesign then, we work on the development of the acute service model has almost concluded. There's been the cross-check event, and we've also had a really successful public engagement event on the 6th of June, where the public could view the proposals and ask questions, and work on our community services. We were late to start this. There seemed to be the plans for the hospital going at pace, and the community services element not being considered kind of up front. So we've managed to gain pace on that, and it's progressing quite well. And we had presentations at the cross-check event and for the public engagement event as well. And of course, with the joint strategy, there'll be more opportunity to engage in the care and rehab models and prevention models going forward. In terms of North Coast redesign then, that's progressing, the hub model's progressing well. Carlosona residential care home has been closed, with the residents safely moved to alternative local placements. A key risk in the north around the hubs and the hospital redesign is workforce sustainability. So when we were up at the cross-check event, there are big risks around our future development of workforce, and how we're going to articulate that they'll definitely be retained and be in place for our plans going forward. So we're going to take a more detailed update back to the community SLT in July around the North Coast redesign, so that we could fully, as a management and leadership team across the community, understand the project risks and have some clarity around the workforce plans accordingly. In terms of Caithness Hospital redesign, there's been a number of workshops. There's 12 departmental work streams within the upgrade for Caithness General Hospital. That's going really well, and being supported by the project team, and target operating models have been identified and articulated at the cross-check event, which was really good to hear. You got a real sense of the whole of everything that's being provided. In terms of the Health and Social Care Annual Performance Plan, I've talked about that earlier. I just want to highlight that we'll bring that to the next Health and Social Care Committee on the 30th of August. It's due for publication in September. Ross Memorial Hospital, I was asked to put something into my Chief Officer's report about this. So discussions are ongoing. We're engaging with the community and in particular with the rheumatology clinicians. So that engagement is ongoing. One thing I did want to mention was the awards. So there's been an honour for Cathy Shaw, who is a lead advanced practitioner for the remote and rural Skye team in Skye, and she has been recognised and awarded an MBE. And also Dr Miles Mack within the Dingwall Medical Group has been awarded an OBE. One thing I wanted to reflect on just when I was talking about these awards was that last month I attended the Highland Council. That was my first meeting attending there of their Health, Social Care and Wellbeing Committee. And at the start of the committee, there was a celebration of success in terms of projects or staff, things that had been done, innovations, new things that were happening, things that should be awarded. So I wondered if we could maybe have a think about that going forward for our Health and Social Care Committee, just around bringing some of these, new innovations, new practice, where teams are celebrating success, where they've been innovative, etc. And maybe just have, it was only a 5-minute verbal and a short presentation at the beginning of the meeting, but I think it fairly set the scene in terms of staff experience and engagement, which I wondered if the committee might want to consider going forward. And that's me. Thank you.
Thanks, Pam. Yeah, that good idea. Your last few comments, and I think it's appropriate for the committee to congratulate both recipients of the awards that you've mentioned, and on behalf of the committee, just to send congratulations to them. So well done there. And if I can just open it up to members of the committee who may wish to ask questions. Michelle.
Thank you. Hi. I just want to address the Ross Memorial Hospital, please. I'm actually one of the stakeholders as a patient representatives with the rheumatology unit involved in some of that discussions. And I have some concerns that the Chief Officer's report is showing that there is no update for this. In my position as the independent representative on this committee back in January, I brought forward the uncertainty surrounding the fire compliance works within the general ward at the Ross Memorial Hospital. And just to remind this committee, the Fire and Rescue Service advised at that point that general ward patients must be moved as a priority from the area that was a fire risk. Now, the solution for the fire compliance work was approved from the senior leadership team to undertake an organisational change process of existing services being reconfigured. Most importantly, the idea was to move the general ward patients out of the older part of the Ross Memorial Hospital and create some beds in the rheumatology unit, and moving the rheumatology outpatients and very busy infusion service to where the general ward currently is. Now, these changes would simply resolve the fire compliance issues discussed earlier this year. And with the challenges we've heard today around care at home sector and all those information that's going on, surely this should be a matter of priority for the health and social care. We were assured that there would be no service disruption in January. The questions were asked how could active services continue in an area where works would need to be undertaken to move the general ward beds, and of which there is still no clear ideas about that. Now, I'm aware that the Finance Department approved a workforce planning team in May, and this has been progressing well in providing the tools to calculate the staff needed in a joint working environment. But that work is now coming to an end, and in order to progress the redesign project as approved, and which is a significant part in terms of reconfiguration layouts, design element and financing the project, a project manager needs to be put into place. Now, despite being escalated on a number of occasions, and the Chief Officer telling me at the last previous meeting of this committee that a project officer had been appointed by estates, that's simply not the case. This project cannot be taken forward any further, and there appears to be some stonewalling and deflection going on within the organisation. Now, we've got a reputational issue here for the community, the patient groups, and most importantly to the staff. And the stalling of this project makes a mockery, quite frankly, of the Together We Care and community engagement project frameworks. Authority was given to progress this reconfiguration project by NHS Highland, and they're not putting the resources in to support that and to take it forward to the most crucial stage. 7 months later, the general ward patients are still in an unsafe part of the building. So some of the key questions I've got today for you, Pam: how are you going to resolve the fire compliance issues that clearly is an organisational risk? What are your intentions around the redesign works? And what are your plans about the future of the Ross Memorial Hospital? Is it the case that you're actually revisiting the whole Ross Memorial Hospital building and services rather than just progressing with the fire compliance works? And I think another more important question that I have as well is, we appear to be allowing estates to decide what will or won't happen to the Ross Memorial Hospital, and this project has been stretched out for far too long. And as the project manager has still not been put into place or even started looking at the redesign work, that's a big worry for the future of the Ross Memorial Hospital and all the services within. So why are estates, a support service, driving NHS strategy when the clinical people should be driving that strategy and a support service should be following?
Okay, Michelle, I think I can come in here and say that I don't believe that there is any deliberate stonewalling or any issue there in terms of not providing access or information to what should be happening. I do understand that there is an engagement group and there is a project which is set up to deal with the Ross Memorial. And whilst there's no difficulty in airing issues of the health and social care, I think this strays into the region of a specific project which there is already mechanisms set up to deal with, Michelle. So whilst not wanting to poodle you off and not provide you with assurances, I think that this should be perhaps brought up in a different forum. I don't know if you would quite agree with that, Jerry.
I think Michelle has raised some valid questions, which I think it is important that get answered. But I would totally agree with you, Philip. I don't think the committee in its governance role. I think what the committee's role is to get the assurance back that the project is proceeding within agreed engagement and process and everybody's content or has been involved in how it goes forward. But I think we have to, and we'll let Pam come in. It's just a matter of how will, and if Michelle is a member of the stakeholder group, are these discussions happening at the stakeholder group? I suppose that is a question. But I totally agree with you. I don't think it's for this committee in a governance role to get involved in that level of detail. But what we have to make sure from the assurance point of view is that these legitimate questions are actually being allowed to be asked and then answered in an appropriate manner. That's not to say that everybody will be content with the answer, but they've got to be provided with the appropriate answer within a reasonable timeline.
Thanks, yeah. So a couple of things. There's no stonewalling. Estates don't make the decisions around whether or not we're going to invest in projects. You know, we engage with the stakeholders and estates respond accordingly. What I would say is Dr. Claire Copeland, our Deputy Medical Director, visited last week and Kenny gave her a look round of all of the plans. Myself and Pam Dudek are coming up for a visit. We are completely engaged in this. So I don't think this is the right place to have the debate. You know, we are going back to the participation and engagement process with our stakeholders already set up, and we'll take that forward through that route, Michelle. So I can only offer you the assurance that you know we are as senior leaders going to be visible around this project. And that Dr. Claire Copeland has already been and engaged, and she herself wanted to go and engage, particularly around the joint working with DPs and making sure, you know, just rechecking and reframing with stakeholders. So it's all happening, and I don't think it's a debate for this committee because we're not debating it with the right people, to be honest.
Pam, could I ask that you pick up those issues with who should be picked up with them so that Michelle gets all the responses and all the answers to the questions that she requires?
Will do.
Thanks very much. Are you happy with that, Michelle?
Not really, no, because you've not really answered any questions, but I would like to have those questions answered, please. And no, I do think there is some stonewalling. I've been involved in the engagements that's going on, and unfortunately the district manager himself is at a loss as to why a project team member has not been put into place to put this forward.
Okay, as we say, there are questions that are legitimately being asked. They're not for this committee to deal with in our governance capacity, but we will ensure that Pam directs the appropriate person to answer those questions, and they can pick up on that. So thanks very much for that. Any other issues that anybody would like to pick up on the Chief Officer report? No? Okay. Then if we can just move on, and if we can, we were going to have district reports, but I noticed they've been deferred until the next meeting in August. So that then takes us on to the committee work plan, and it's in the papers, and you can see the detail of the reports that we've got in the next meeting's work plan. What I will say is that it seems quite a substantial agenda, and it might be, and I'm not sure if this will be welcome, but you can tell me, I'm sure, it might be we need to extend the next meeting to deal with this rather than put items off until the meeting after. Anne, you've got your hand up. I'm not quite sure if it's in response to that suggestion or something else.
No. And well, I think if that's what needs to happen, then you know, certainly I'm with, in terms of having, you know, the appropriate breaks and everything. I've no objection to extending the meeting if that's necessary. But no, it was really well, it's related to both items 4 and 5, Philip. I think it's important for us to note that this is the second time that the district reports have been delayed, and I can well understand why. So you know, I understand that there's a capacity issues, but I think particularly in the light of the internal audit report on community planning, which some members of the committee won't be aware of, but some of us are, which raised some concerns about how this committee is dispensing its functions in relation to community planning. I think we do need to have a rethink about just how we're addressing our health improvement and community planning side of things within the context of a really highly pressured agenda, because I don't think that situation is going to change really. So it was really just to flag that up and to ask if that it could be given some consideration, you know, before our next meeting. Thanks.
Thanks for that, Anne. And I'm conscious that Jerry will be chairing the next meeting, and we've got a thumbs up from Jerry there. Pam.
Thanks. In terms of receiving the audit report and providing the actions, one of the actions that I did put into the report was for the committee here to have a development session, both you know, for everyone to understand our role in community planning and community engagement, and also to you know, seek the reassurance where the community planning partnerships are working well. Some areas have locality plans, some don't, and for us to understand the differences why that might be. And of course, we've got very significant service redesign programmes in place where there is no locality plan, and we've already raised issues about community engagement within those processes as well. So that would be good for, I had suggested as part of the actions that were agreed by the committee, that by the audit committee, that one of the actions would be to use one of our development sessions to present that audit report.
Grand, thanks very much. So on that basis, I think I'll suggest that we extend the next meeting. So I think the anticipated start time is 1 o'clock, unless again it clashes with staff governance. But we can have a discussion with Stephen about that, just so that we were able to get all of the agenda items sorted.
I think, Philip, what I would suggest is that I'm going to have a good catch up with Pam on Friday, and we'll have a look at the future agendas in line with the work plan, and actually the things that are arising which were never factored into the work plan, indeed in capacity, and maybe see if we can come up with a revised programme for the rest of the year, and including start and finish times and breaks and all of that, because I think that's, but recognising it will undoubtedly be fluid, but I think as a general principle we do need to look at it. I've got no problem with extending meetings, but we have to be cognizant of people, and I'm talking for myself, but people's ability to actually reasonably be having good discussions after 4 hours. It's a big ask of folk.
No, right. Yeah, absolutely right. And the committee is asked to note and agree the work plan. So what we'll do is we'll note it, and we'll note that it may be fluid. Okay, thanks very much, folks. And that then brings us to any other competent business. So if anybody wishes to raise any issues, then no, okay, I think that's us exceeded our time, but we had a reasonably heavy agenda, and I'll just thank everybody for their participation. And the next meeting will be chaired again by Jerry, should this recuperation continue to proceed as well as it has, and we will be back on time. Thanks very much, folks.
Thank you. Bye.
Bye now. Bye.
Thanks, goodbye.